So the first question I'd like to open up with, Andrew, is how you first got into cardiac CT, coming from a nuclear background, and in what decade this occurred.
Well, it was in the noughties, really, while I was still a consultant at Harefield, and cardiac CT had become possible. We bought a 64-slice scanner, and together with my radiology colleague Taran Mittal, we set up quite a novel approach to it. What we did was we took people off my very large nuclear perfusion scanning waiting list, and we selectively moved some of them onto the cardiac CT list, feel our way as to what the correct indications might be and what sort of patients would give good pictures and what sort of patients wouldn't give good pictures, and then sort of grew from there.
So leading on from the first question, the thing I'd next like to ask is what translational advance excites you the most for the future of cardiac CT, if anything?
I think that's a difficult question. I mean, what I always think, the most important advance in any imaging modality is just improved image quality. I'm often a bit sceptical about some of the fringe things that people do beyond the core of what the imaging technique is for. I mean, I think what's going to be very interesting is vulnerable plaque imaging. I mean, you allude to the fluoride PET story. I think realistically, fluoride PET is not going to be an everyday tool. What we need is cardiac CT markers of vulnerable plaque, which are perhaps more specific than the ones that we've got. I mean, we know we have markers for plaque vulnerability, but we know that any given vulnerable looking plaque is most unlikely to actually cause an acute coronary syndrome.
Sure.
So as at the present state of knowledge, nobody in their right mind ought to be stenting a vulnerable looking plaque which is not causing a flow limiting stenosis. What we'd like to be able to do though is really identify a plaque that is going to cause an acute coronary syndrome within the next 6 months. And then perhaps stenting it might be of value. I think we're quite a way away from that, but the work in that area is going to be very interesting. As you know, in Oxford we've been involved with Claris in his work on imaging the pericoronary fat and looking at the ability of that to predict the risk of an acute coronary syndrome, and that's very interesting work. Whether that will actually translate into prime time imaging or not, I think remains to be seen.
As everyone knows, you and another esteemed colleague within the BSCI recently assisted in the development and update of the NICE guidelines on cardiac chest pain. Putting the national audit figures aside that the BSCI publish, how do you think the implementation of this is going locally and perhaps nationally, and also the uptake of these guidelines?
Well, I think as anybody who listens to me banging on about it constantly, my concern is that actually the NICE guidelines are not being implemented properly. That's not to say that we're not doing ever more coronary CT scans, but my concern was and is that the NICE guidelines are being misread. NICE doesn't recommend coronary CT for all comers with chest pain, but that is how it's been interpreted. NICE recommends coronary CT for patients with typical or atypical angina. My suspicion is that if we were to actually implement the NICE guidelines, we would be doing a few more cardiac CTs, but not all that many more. If you ask me, are we locally doing far more coronary CTs than we ever were before, then the answer is a resounding yes. But the difficulty that we find is that when you do a coronary CT scan in somebody where the indication is questionable, it ends up generating more questions than it answers. If you've got a patient with musculoskeletal chest pain and stenoses on a coronary CT scan, it's still musculoskeletal chest pain, only now that poor patient knows that he's got coronary stenoses. So that then leads to probably functional testing, which may or may not show inducible perfusion abnormalities or inducible wall motion abnormalities, or you send your CT scan over to America to get FFRCT, and you emerge £700 poorer for the privilege. And again, they tell you that those stenoses are or are not flow limiting, Still, you've got a patient with musculoskeletal chest pain and not angina, and that patient probably ends up in the cath lab and ends up with a stent, and at the end of it, guess what? They've still got musculoskeletal chest pain, and we know that stenting stable coronary disease does not make you live any longer.
The next thing I'd like to ask you about is your sub-interest in congenital cardiac CT, which you lead on here in Oxford as part of the ACHD programme with Liz Orchard. And I guess regarding that, I'd like to ask what you think cardiac CT offers that cardiac MR doesn't or cannot.
I think it's fantastic. I think that if cardiac CT had matured as a modality before cardiac MR came along, then people would kind of look askance at the idea of using cardiac MR for a lot of patients with congenital heart disease. Obviously, MR gives you functional information, flow information that you don't get easily from cardiac CT, but in terms of the anatomy, cardiac CT just wins hands down. It's got better spatial resolution. You don't need to know in advance what the precise anatomy is to get the correct stack of slices and sequences done, because you're going to acquire a nice three-dimensional block of data, whatever the anatomy might be, and you can then, at your convenience, slice that in any plane that you want. So we are forever finding aberrant pulmonary venous drainage that's been missed on the cardiac MR. We find coronary anomalies that have been missed on the CMR. You can, as you know, get, if you do the cardiac CT correctly, and now at really not very high doses, if you modulate the dose through the cardiac cycle, you can get lovely LV and RV function as well. So you can get an awful lot of information out of the cardiac CT scan, and it's a lovely test.
And to finish with, the big questions everyone really wants to know the answers to. Firstly, will you be involved in next NICE appraisal? And if so, can you give us an inside track?
Well, I can't imagine that anybody will be really interested in the answer to that question. I mean, I haven't heard anything about the next update, and presumably if and when they decide to do it, they will ask for people to apply to be involved, and I might very well throw my hat into the ring. I think, to be honest, they're going to need to start again. The problem with the latest review is that they took the premises of the original NICE guideline, predicting what the invasive angiogram would look like rather than any sort of meaningful clinical endpoints, and they then forced us to take changes in modalities and look at the value of those, but against the old NICE guideline. They need to start again, fundamentally. Start again with proper clinically relevant endpoints, and that's going to be expensive, and the question is whether NICE will have the money to start again. But yes, I'd like to be involved if they'll have me, but who knows when it'll happen.
Thank you for being honest. And I guess the last question, and most importantly of all, if we were playing Kiss, Marry and Divorce with CT, nuclear and echo, how would you choose each modality and why?
Okay, well that's a very difficult, it's a difficult question, and it's a false trichotomy really, because of course they all have strengths and weaknesses, but equally some of them are indispensable and some of them you can work around not having. So it's impossible to imagine practicing modern cardiology without echo. So, and not just for imaging, obviously not particularly coronary disease, but for valve disease and ventricular assessment or whatever, you couldn't function without echo. So echo is a given.
You'd marry it.
Yeah, I'd marry it. I mean, if the three modalities are in a balloon, you've got to keep echo. There's no doubt about it. Number two, I mean, the truth is that cardiac CT is more versatile than the nuclear techniques, and so I definitely have to kiss cardiac CT.
Okay, and I won't force you to say that you're divorced.
But nuclear is a great technique for the particular situations where it answers a question. So I still think it's a fantastic functional assessment for patients with suspected coronary disease. We can scan all comers. I don't care if they're NAF, I don't care if they're hugely obese. We can scan almost anybody and get the information, and we have robust prognostic data, and nuclear is a fantastic technique, but it doesn't tell me anything about the severity of your aortic stenosis. It doesn't tell me very much about complex congenital heart disease. So, these are more niche techniques, and therefore, unfortunately, nuclear cardiology, much as I love it, is going to be in third place if you force me to do that.
Okay, thank you for being so honest. And as we know, divorce is never final.